Hello, hello. This is Professor White, and today we're going to be talking about acute kidney injury and chronic kidney disease. So, your paper may actually have like some CKD here. That's okay. I suspect that we'll talk a little bit more about chronic kidney disease under the dialysis lecture. But of course, dialysis can be used for acute kidney injury as well as chronic kidney disease. But we'll talk about acute kidney injury for the most part here and how it might compare and contrast. So that being said, let's always take a nod to our next-gen reasoning, including recognizing and analyzing cues, prioritizing our hypothesis, so what would be the most important things, whether we fix something or what happens if we don't, generating solutions, taking action, including evaluation of the patient, and then some medications to know. Okay, so first and foremost, let's talk about the difference between, what is acute kidney injury and how does it differ from chronic? Acute kidney injury is a sudden decrease in kidney function, so it's sudden, versus chronic, which is basically not sudden. Some definitions say that sudden would be less than 3 months in duration, cause, and chronic would be greater than 3 months. So that would be the big difference between those. And there are many different reasons that our little buddy bean might be feeling sad, why it might get acute kidney injury. So in acute kidney injury, we look at three specific types of acute kidney injury, whether it is pre-renal, intrarenal, or post-renal. So what does that look like? So as we know, our kidneys are fed, right? They need vessels to give them the blood supply, and then the kidneys do their magic, and then on the way out, they excrete the urine. So that's why I have the different colors there. So we have three different types of kidney failure just based on this right now. So if we have a problem with perfusion, so the blood supply to the kidney, we're going to just make it a little darker mark here. So anything to do with the blood supply, that is called pre-renal, right? That's a hypoperfusion. So what would cause perfusion issues with the kidneys? For acute kidney injury would be things like clots, emboli, tumors. If we just don't have enough blood flow, so decreased blood pressure, so if our heart is not giving good cardiac output, that can lead to a sudden decrease. That could also lead to chronic kidney disease as well. However, for chronic kidney disease, the number one causative factor is hypertension. All right, so that's pre-renal. And then we can have a problem with the kidney itself and, its little nephrons. And in that case, that would be considered intrarenal. Intrarenal. So how does that happen? That's damage to the kidneys itself, to the renal parenchyma. Things like meds, like IV contrast, antibiotics, especially like that vancomycin, those minomycins meds. Those are your major causes. And then we have post-renal. So that would be after the kidney, post-renal. And those would be things like obstructions in the urinary tract from the tubules to the urethral meatus. So that might be renal calculi, right? Renal stones. It could be tumors. It could be BPH. Remember that enlarged prostate. Anything that obstructs the flow of urine out can lead to post-renal dialysis, post-renal acute kidney injury. All right, so some other things that can cause kidney injury would be trauma. Remember, our kidneys are very vascular. Genetic causes like polycystic kidney disease, burns, surgery, heart failure, sepsis, like so anything that's going to affect the blood flow in, the function of, so blood flow in, function of, or urine outflow can cause a kidney injury. And acute kidney injury, good news is that it's potentially reversible. But the bad news is if you don't reverse it, it can lead to end-stage renal disease and the need for dialysis or death in the patient. What's interesting is that with recovery for acute kidney injury, 70 to 80% GFR would be usually what we recover. So as long as the kidneys can still filter. So let's recognize and analyze the cues. Now, obviously stuff in the patient's medical history can clue us into potentially what's going on, and then we can look at some specific things. So let me just kind of scroll in here and we'll go into this section. Okay, so recognizing and analyzing cues. So there's some certain risk factors that go along with the development of acute kidney injury and even just chronic kidney disease as well. Some things we can do something about and some things we can't. And that's the difference between modifiable and non-modifiable. So non-modifiable and modifiable. So what are some things that you can think of that might be non-modifiable? Right? Things like age, their past medical history, you can't change that. Things like cancer, liver, renal disease, diabetes. And things that are modifiable that often cause acute kidney injury, of course, antibiotic use, medications, chemo, heavy metals, IV contrast. That's a big reason why we always ask about the person's renal function before we give them IV contrast. So what are we going to see? First sign that we're going to see in acute kidney injury is fluid retention. All right, so how does that look? That looks like decreased urine output for sure. And that then leads to fluid overload. It can lead to things like edema. That's what we'll see, right? Weight gain. See that. Hypertension as we have an increased intravascular volume. Some other signs and symptoms that somebody's got too much fluid. Let's think here. Jugular venous distension. Their pulse may be bounding. Right? So think about all those things that can show us that somebody's got too much fluid on board. Eventually, if we don't correct this, this can lead to pulmonary edema, which, of course, we would hear upon our assessment of the lungs. It can lead to respiratory distress, respiratory failure. And remember, anytime we're talking about respiratory, that is an airway priority. Remember A, B's, and C's. So that is a huge priority for us. Some other things that we'll see. Changes in our electrolyte imbalances. So what will we see? What's the most dangerous one you can think about? Especially increased potassium. Sodium tends to decrease. Calcium decreased. Then here we get that fancy word azotemia, right? So azotemia, which is our BUN and creatinine. So if you hear that, that's what that's really talking about. Increased phosphate. You see that in a lab, usually written as PO4. So uremic signs and symptoms, generalized signs and symptoms of uremia can lead you to things like weight loss, anorexia, right? Decreased appetite, nausea, vomiting, uremic encephalopathy. Okay, so uremic encephalopathy, which can manifest as things like confusion, lethargy, change in their baseline. And again, any of these can progress to end-stage renal disease. There are a couple phases that you need to be aware of in acute kidney injury. And so let's put the phases here. The first phase is oliguric, right? Doesn't that make sense what we just talked about if you look at what oliguria is? So for us, we're going to look at the adults, which would be less than 400 mLs per 24 hours in our book. And that is what we're going to see all of the fluid overload issues with. Then we have the diuretic phase. And this is, as we progress through it, this is when the urine output is greater than 400 in 24 hours. So that's ml, cc, same thing. And so what happens when the person's urinating too much? Well, then we might see the opposite of too much fluid on board. We're going to see too little. So we might have decreased fluid volume, decreased potassium, sodium still would be decreased specific gravity. So that's important to note depending on what phase you're in, you're going to see. But the first sign of AKI, of course, is the decreased urine output if we're in the oliguric phase. Now, not everybody always has both phases of this. So something to note, just a little different. And then, of course, we have the recovery phase. So recovery phase, and that's, again, I kind of mentioned, that's when the GFR is 70 to 80% of normal. All right, so we're going to pause there for a minute. Like, what do we see? I want you to think about the picture of the patient that you're going to potentially see. And I'll have some examples in class as well. So next we're going to go down to relevant diagnostics. All right, so hopefully you guys can see my writing here. It doesn't show up too big or too little. It might be big. But to start to diagnose renal failure, so the creatinine clearance, so that's one test we should know, creatinine clearance. And remember that a creatinine clearance urine test is a 24-hour urine. So everything you know about 24-hour urines applies here. And the one thing we do know is that the creatinine clearance effectively kind of looks like the GFR. We could do our labs, our chemistry labs, so BMP, CMP. And the ones that we're looking for here are pretty specific. What are we going to see? We're going to see increased BUN. Whoops, what happened here? Increased creatinine. If we did a blood gas, so ABG, it might show, what do you think? Well, we have renal problems, so it's mostly metabolic acidosis. Right? We can't get rid of some of that waste. Of all of these, GFR, probably the most useful in the diagnosing of kidney function issues. We did a UA. UA could be helpful. It could show us some causes potentially. We might see protein, CAS, RBCs, right? Sort of a screening tool as well. We might need to investigate why the person is having the acute kidney injury. So things that help us would be like the intravenous pyelogram, so that looks at the perfusion of the kidneys. And also we might need a renal biopsy. So renal biopsy, do you guys know how to take care of a person who's had a renal biopsy? Yeah, we'll talk about it. I hope you're thinking about the potential complications after a renal biopsy. All right, so that's the major parts of diagnostics for kidney disease. All right, so let's talk about some of the things that can happen based on treatment and also based on not treating. So if we don't treat it, end-stage renal disease generally will result, which can lead to death. Some of the other problems. Of course, we have fluid overload. Kind of talked about that already. So fluid overload, this is a priority. We can't have too much fluid on board because that can lead to pulmonary edema, and that can lead to respiratory distress and failure. And that is an airway issue, my friends. All right, what else? We have those electrolyte disturbances. What do you think is the most likely to kill the person? Hopefully you're saying hyperkalemia. Potassium kills. We can only have it in certain range. Remember what that range is? 3.5, so generally like 5, 5.1. The higher it goes, the more likely it is to cause harm and dysrhythmias. The lower it goes, the more likely it is to cause harm and dysrhythmias. So we really want to make sure our patient is maintained in a safe range. So of all these that are happening, what would be your priority? Remember your A, B, C's, no matter what question you're looking at. What sort of disorder? Airway, breathing, circulation. So that should help guide you. Airway is always first. And a dysrhythmia technically is a circulation issue, isn't it? Fluids. Fluid can be circulation, but because of the potential of the respiratory, we're going to put it in the airway. Okay, we're going to go over to take action. Okay, so generating solution, take actions. Somebody with acute kidney injury. A lot of it depends on what phase they're in, but if they're in the oliguric phase, a person generally needs a fluid restriction because they're fluid overloaded. So oliguric, we would ask ourselves, maybe we need to decrease their fluids because they've got too much. And then if they're in the diuretic phase, we would need to increase their fluids because they don't have enough. So that's important to think about. We need to stabilize their fluid and electrolyte status. So this looks an awful lot like making sure they're not hyperkalemic and then treating the patient supportively who is. So we want to treat the hyperkalemia. And how can we do that? We can do that with dialysis for sure. If it gets too high, it's too dangerous. Fluids in general are not contraindicated. You'll have to forgive me because we had a fire drill here in the middle of recording, so I don't know if you heard it, but if you did, I apologize. I'm back now. So let's look at some other things for the person with the kidney injury. So we definitely want to monitor their urine output regardless if they're oliguric or in the diuretic phase, and make sure that we have the provider aware of any changes that they need to be. Remember, our goal for urine output is 0.5 mLs per kilogram per hour. And that's really good because that helps us delineate based on weight a little bit. All right, so we want to make sure that the person has enough fluids but not overloaded. We talked about that because that will help us with the prerenal causes. Intrarenal. So when we already have a kidney that's hurting, we want to avoid intrarenal damage. So how do we do that? So definitely we want to avoid those meds which can cause kidney failure and kidney damage. NSAIDs, that's a big one. Your Motrins, your salicylates. So Want to avoid those. PPIs. Contrast. Aminomycins, right? The aminoglycosides. We want to monitor, going back to the potassium and the fluid and electrolyte, how do we monitor their cardiac status, right? We might need tele, might need EKG for any changes. Looking for the peak T waves as a potential. We want to avoid magnesium supplementation. We want to make sure that we can manage their phosphate. So remember, mag and phosphate are big deals for kidney function. We'll talk about that a little bit further. So good nursing care has our vital signs, has our I's and O's, has our daily weights, has our baseline cardiac assessment, monitoring their fluids. Sorry about that, I just hit the button behind it. So monitoring their fluid status. There's dietary things we need to consider. So what do we really want to avoid? We want to avoid high potassium foods. So what are those foods that are high in potassium that you can think of, right? Apricots, bananas, cantaloupe, orange juice, spinach, fish. Avoiding Mrs. Dash, right? That Mrs. Dash is bad for our kidney patients because that can cause hyperkalemia and the fact that it has a lot of potassium in it. We might have to do a renal transplant. So a renal transplant has its own set of things. Usually that's chronic kidney disease, but I've just mentioned it over here. Especially, we may have a person with a renal transplant who's experiencing acute kidney injury. And at that point, we really need to try and save the kidney as much as possible. I think that's a lot there. All right, so let's go down to meds. ACEs and ARBs, they can be problematic. Okay, so we're going to head down to some of the medications to know. So certain things, like if we're treating pre-renal azotemia, a lot of times what we would give would be diuretics, ACEs, beta blockers, nitrates. Basically, we want to treat those conditions which can lead to decreased perfusion of the kidneys, so things like treating the congestive heart failure, so that alone can be helpful. We want to correct the fluid and electrolyte imbalances with potentially IV fluids, so crystalloids would be preferred. We'll talk about this under dialysis as well, but avoiding certain things like avoiding the magnesium, we might need to give medications to decrease the potassium. So those would be like Kayexalate, potentially regular insulin. We'll chat just a minute about if somebody was to have a renal transplant, that we would give them corticosteroids. So for transplant, so that might be steroids, and again those are corticosteroids. So corticosteroids, things, the other meds, tacrolimus, cyclosporin. So again, that's just under if the person has a transplant. And just be very careful because they're ACE inhibitors. If we're using those can cause potassium retention, right? So want to just be careful with that. So I know this is kind of long and sometimes I'm sort of all over the place, but this is basically acute kidney injury with a little bit of chronic thrown in there. And we'll talk about the stages of chronic kidney disease and stuff as we get into the dialysis lecture. So if you want to know more about that, let's head on over there. And thank you for your attention during this lecture.